Thank you. Good morning, and should I say bonjour from South Africa. I'd like to relay a very warm greetings from all my colleagues in South Africa. I'm sorry my French is not good enough to give this talk in French, but I hope you bear with me. Our association with the SPOI goes back quite a few years, and we'd like to see it grow. And I have had a lot of discussions with Radha over the years. And our current president, who took over from me in August, is Professor Umesh Lalu, who I think you all know, and he sends his greetings as well, and his apologies that he can't be here.
Sorry. Est-ce que quelqu'un veut qu'on traduise un petit peu? Do you want to have a translation of your meeting? Because perhaps many of people here won't understand what you're saying.
Oh.
So either you or me can have the translation. Tu peux dire, si vous voulez, on peut faire une traduction, essayer de faire une traduction. Toi, tu vas le faire peut-être mieux que moi. Pardon? Ouais, je comprends. Tout le monde comprend. Alors, qui c'est qui comprend pas? Qui voudrait une traduction? Levez la main. Ceux qui voudraient une traduction. Ceux qui voudraient une traduction en français. Je pense qu'il y a peut-être qu'est-ce que tu penses? Moi, je pense
Sorry. It's okay. Thank you. Okay. It always makes me very sad to talk about COPD, because it's a socio-political disease. It costs a lot of money, costs a lot in health, and it's a disease that's easily preventable. And as you've heard, it's mainly due to smoking in the developed world, but in the developing world, it's biomass fuel, etc. And we believe that in the third world, we're sitting on a volcano that's about to erupt, because it's not only due to these, it's the combined contribution from smoking, from TB, other respiratory infections, HIV, and biomass fuel, and pollution, obviously. So if you put all those together, we're heading for a huge epidemic of COPD in the future. And like I said, the biggest problems we have is failure of prevention. The other big problem is underdiagnosis or misdiagnosis, where people label it as asthma instead of COPD. There's been studies showing that in patients with COPD, maybe 30 to 35% of the patients only have had spirometry. So one questions how the diagnosis was made in many of these places. The abuse of inhaled corticosteroids in COPD, and you've heard about some of the aspects of non-smoking COPD, and a lack of public awareness of the term COPD. Many times I see my patients and I tell them, you've got COPD, and they say, doctor, what's that? They've never heard the term, and you have to educate the public about it. And then COPD versus asthma, I'm sure you've heard this many times. Are these really the ends of a continuum of disease like the Dutch hypothesis? And I recently heard one talk where the speaker said maybe we should stop talking about asthma and COPD and talk about chronic airways disease, which are different in terms of phenotypes, in terms of inflammation, etiology, but they may share common factors. So we should start thinking of it as chronic airways disease rather than labeling them specifically as COPD and asthma. And like I said, it's a heterogeneous disorder. Don't forget that there are a lot of comorbidities. And the biggest problem we have is most of the studies that are done now are for drugs that need to be licensed for use. So they are sponsored by the pharmaceutical industry, and unfortunately the data will be biased. So we base a lot of our recommendations and guidelines on studies that that are for licensing purposes, and I think we need to bear this in mind. Okay, I think all of you are familiar with this from the GOLD strategy, where COPD is divided into 4 groups, A, B, C, and D, based on severity of symptoms, the spirometry using the old GOLD criteria, and the risk of exacerbations. Okay? So the more exacerbations you have, the more severe is your COPD. The worse your spirometry, the more severe your COPD, and the increase in symptoms makes your COPD worse. I'm sure you're all familiar with this, and I'm not going to bore you with that. All right. Now, my task is to just talk about the treatment, and it was supposed to follow on the previous, Prof. Ben Kedder's talk on COPD. And I think you'll all agree, smoking cessation is most important. Pharmacotherapy and nicotine replacement is useful to enable smoking therapy, and then regular exercise. You've heard about exposure, indoor air pollution, the importance of good air quality. Tobacco control policies is a big stumbling block for us, and this is one of the biggest problems we have in smoking cessation. If we could ban the production of cigarettes, then we don't need to go through all of this. And then improving exposure in the workplace. We can, using the right drugs, reduce symptoms, reduce frequency and severity of exacerbations, and improve health status and exercise tolerance. But none of the medications modifies a long-term decline in lung function. Neither have they been shown to reduce mortality. And then don't forget vaccination. Okay, these are the drugs we have. I think all of you are familiar with these. The short and long-acting beta-2 agonists, short and long-acting anticholinergics, combinations of these two, the methylxanthines, corticosteroids, combination of LABA and corticosteroids, systemic corticosteroids, and PDE4 inhibitors. Bronchodilators are central to the treatment of COPD as opposed to asthma, where your inhaled corticosteroids are central. You can either use them as needed or regular, and the main ones are beta-2 agonists, anticholinergics, theophylline, or combination. Obviously, the choice depends on availability as well. There are many parts of, in South Africa, there are many parts of the rural areas where they may not even have all the drugs available, so it depends on what's available and how the patient responds as well. Okay, the long-acting bronchodilators, as you know, are favored because they're more convenient, more effective. They reduce exacerbations, exacerbation-related hospitalizations, they improve symptoms and health status. And combining different classes may prove more efficacious and decrease the side effects. Regular treatment with inhaled corticosteroids has been shown to be effective at reducing exacerbations for COPD patients. You'll notice the FEV1 goal has been shifted to 60%. Previously, we used to say less than 50% with exacerbations is where you would use the inhaled corticosteroids. But post hoc analysis of some of the bigger studies have shown this benefit even at 60%. But not to forget the risk of pneumonia, and at the moment the GOLD strategy says that withdrawal of inhaled corticosteroids may lead to exacerbations, but we know about the WISDOM study which says otherwise. Using the combination of an inhaled corticosteroid with a long-acting beta-2 agonist is more effective than the individual components. And the combination is also associated with the increased risk of pneumonia. Combining the LABA, inhaled glucocorticosteroid, to an anticholinergic such as tiotropium appears to provide additional benefits. Systemic corticosteroids, meaning oral or injectable corticosteroids, should be avoided. Okay? severe and very severe COPD, we could use PDE4 inhibitors if they have this phenotype, chronic bronchitis and a history of exacerbations. And it could be used as an add-on at step 4, but I'll show you that just now. Theophylline, not as favored as they are, but I think in the third world, they still have a role to play because of lack of availability of some of the other agents. And don't forget your vaccines. Antibiotics at the moment recommended just to treat infections, but there's emerging data to show long-term antibiotics like azithromycin may reduce exacerbations in COPD patients. Exercise, pulmonary rehab, very important. You know the role of oxygen therapy. It's been shown in 2 studies, which are quite old now, to reduce, to increase survival, especially in those who have severe resting hypoxemia. And I think this is another modality that's abused. Please stick to the recommended criteria as it appears in the GOLD guideline or the GOLD strategy. Surgery, I think in the third world, has a limited role because of lack of availability, but lung volume reduction surgery and lung transplantation, and then non-surgical or bronchoscopic lung volume reduction surgery seems to be taking off, but at the moment is reserved for centers which have expertise in doing these procedures. We do have, I think, at least one surgeon in the room who may disagree with me. Okay, now, just to look quickly at the goals of treatment, you know this quite well. The 2 main prongs, reduce symptoms and reduce risk, and the risk reduction is to prevent disease progression, prevent exacerbations, and hopefully reduce mortality. And we must not forget, patients come to us because they have symptoms. They have impaired effort tolerance, and their health status is impaired. And we need to do things that improves this. And the general non-pharmacologic aspects of management is smoking cessation, physical activity, and vaccination for all patients with COPD. Pulmonary rehab probably for the more severe patients, but every patient should be offered advice on smoking cessation, physical activity, and vaccination. Okay, I think this is quite busy, but if you look at the first column, it's quite simple. Your mild COPD with less symptoms, with reasonable lung function and no exacerbations, that's what you're going to do. Either a short-acting muscarinic antagonist or a short-acting beta-2 agonist. As the symptoms become more severe, you would use long-acting bronchodilators. This is in alphabetical order, not in preference of one over the other, but I'll discuss that again a little later. And if they develop exacerbations, you would add on an inhaled corticosteroid in the more severe patient, and then move on to triple therapy. And you'll see the alternative choices. I think you're all familiar with this, but as far as possible, we'd like to stick to the first column. Theophylline come in quite late, but I must say if you go to the more underdeveloped or less developed countries, theophylline are still being used as add-on or as treatment. Can you see that? Okay, so what some of the unanswered questions we have with this approach is, should we not be looking at using long-acting bronchodilators earlier? Because they're more convenient, the patient's got to take it just once a day and been shown to be effective. Why use short-acting bronchodilators more frequently? I think where it is available and the patients are symptomatic, a lot of people believe you should start off by using a long-acting bronchodilator. This is not yet recommended in the GOLD strategy, but it's something we should consider earlier on in the treatment of COPD, if it's available to use. Then the big question is the role of inhaled corticosteroids. Okay, it's quite controversial. We currently know that GOLD recommends it at in patients rather who have an FEV1 of less than 60% and who have exacerbations of, as you saw, more than one or two or more exacerbations, then you would use an inhaled corticosteroid. But I think if you think, you apply it in your practice at the moment anyway, patients who have an asthmatic tendency or have a history of asthma, you would use inhaled corticosteroids. Some people believe if you see a good bronchodilator response when you do spirometry, that this is an indication of asthma, not necessarily true. That is not a guideline you can use to say this is a patient who will respond to inhaled corticosteroid. But you could try it. And then thirdly, eosinophilia, the phenotype where you get a higher eosinophil count would do better with the use of an inhaled corticosteroid. So those are the kind of patients you could consider it besides what's recommended in the GOLD strategy. But the big problem, this is a French study, the big problem is that corticosteroids are overused. What is the real life ICS use in COPD? This is mild patients, and that's fixed combination and outside. Close to 60% of patients in the mild category are on inhaled corticosteroids. All right, and this is common in practice, either as monotherapy or as fixed combination. And this study, if you look, has it improved 2014? Very similar. Inhaled corticosteroid use in GOLD A, the red bar, fixed combination. So patients are getting inhaled corticosteroids quite early and probably inappropriately. And we need to think carefully because it's not without risk. And it's not only in France, it's all over the world. This is an Italian study, and you could see that inhaled corticosteroids are again overused. Look at the green bar. So inhaled corticosteroids alone, fixed dose combination, etc. So it's abused all over the world. Okay, and I think we need to, and this might reflect the fact that we are confused about the diagnosis. Many of these patients come in and it could be asthma, it could be COPD. If I give them a combination, it's fine. I'm treating both anyway. Or they don't get spirometry done, which is commonly a problem. And looking at it another way, if you look at stage 1 and 2, this is the overprescription of inhaled corticosteroids. Okay, and this is real life studies. Why do we step up treatments? Because patients may be having more exacerbations, they may be having more symptoms, the exercise is limited, or it's more convenient to use a long-acting bronchodilator. So these are some of the things we would take into consideration when we step up treatment. Do inhaled corticosteroids work? Without a doubt. They reduce exacerbations. So yes, they are effective drugs, but they are being overused. And we know this data quite well, the risk of pneumonia, which was first shown in the TORCH study and reproduced and shown in other studies subsequently. So there is a real risk of pneumonia. This is UK data, which again shows inhaled corticosteroids either as monotherapy or in dual or triple therapy, it's abused in COPD. So what happens now that you know your patients should not be on the inhaled corticosteroid? Should you take them off it? Yes, but the way you do it is important. Previous studies have just stopped them abruptly, and if you stop it suddenly, you have a risk of exacerbations in those patients. But in the WISDOM study, the inhaled corticosteroids were withdrawn gradually in patients who were initially given triple therapy. And with the withdrawal of inhaled corticosteroids in this study, there was no difference in exacerbation rate between those who remained on inhaled corticosteroids in the triple treatment or those who only got LABA and LAMA. Okay? But there was a problem in that there was a slight decline in lung function, which we're not sure how this is going to impact. So one of the approaches the primary care physician takes is short-acting bronchodilators. All patients who need regular treatment should go on to long-acting bronchodilator. And maybe we should now be looking at the ultra-long-acting once-daily LABA or LAMA. And if the patient is not controlled on monotherapy, one could step up and add the other bronchodilator. And the pulmonologist view is just two categories of drugs, bronchodilators and anti-inflammatories, including inhaled corticosteroid. So if you want bronchodilation, in other words, if they have airflow limitation, you're going to add two bronchodilators. And if it causes dyspnea, the bronchodilation can be proportional. In other words, if they have more dyspnea or they're not responding, then you increase your bronchodilation. And only in those who have lots of exacerbations would you add the ICS or inhaled corticosteroid. Should we now be looking at phenotype-directed treatment in COPD? In other words, looking at different markers, serum markers, peripheral eosinophils? And the answer is yes, we probably should be, but this is not yet widely available. So what are the take-home messages? There's many different treatments. Monotherapy with a bronchodilator in mild symptomatic patients must encourage physical activity. The ones who are more symptomatic, we want to use two bronchodilators, and those who have exacerbations, we would like to prescribe a LABA-ICS combination. And if they have a high burden of symptoms and exacerbations, we should be looking at triple therapy, meaning a LABA, LAMA, and an inhaled corticosteroid. We should characterize our patients in terms of symptoms and exacerbations. And in the future, we will be looking at biomarkers to decide which treatment will be used. Don't forget smoking cessation and that we are using inhaled corticosteroids inappropriately. Thank you very much.
Thank you, Dr. GAFFAR, pour cet exposé précis, complet, très clair. Et j'ouvre maintenant la discussion. Y a-t-il des questions?
Thank you very much for your talk. What about the doses of theophylline in these countries? What kind of doses do you use, please?
Okay, theophylline, well, as you know, there's two different approaches. Previously recommended was the higher dose and monitoring serum levels. And you know the data now which shows theophylline also has an anti-inflammatory effect and also has an effect in improving sensitivity to steroids, to corticosteroids, because COPD is regarded as a steroid-resistant dose. The exact dose is not clarified in terms of low dose. We don't know what low dose means. We often would start off with maybe 100 to 200 milligrams twice a day and monitor the patient. But the big problem of monitoring that kind of patient is what endpoint do you use? How do you know it's working? To look at reduction of exacerbations in one patient is very difficult. You can do it in a big study and say so many percent had exacerbations and now fewer. But in the outlying areas where there isn't a lot of supervision, in the rural areas, they use 300 milligrams twice a day, and then patients, some of them get toxicity, and we see them coming in very, from the side effects. So there's no easy answer to that question. Thank you.
Thank you, Sab, for this very interesting talk. My question will be, have you any experience with a combined treatment using ICS and corticosteroid and theophylline?
And theophylline?
Yeah.
In COPD, you would look at both of them as add-on treatment to a bronchodilator. So there is data to show that the addition of theophylline to salmeterol was beneficial in patients with exacerbations. But I don't think there's any data to show using theophylline and ICS, if I understand your question, without bronchodilator. I don't think there's any data. I don't know if anyone else is familiar.
Yes, my question is about the phosphodiesterase 4 inhibitors. Are you using it in South Africa, perhaps? I don't think we are using it in France. I don't know whether we have side effects, I think.
Yes.
So it's not used in France. What about your experience of PDE4 inhibitors?
Yes. There is just one available in South Africa, roflumilast. it's used very little, if at all. I've not used it in my practice. I know of some pulmonologists probably use it in desperation as add-on to maybe triple therapy where it's not controlling the patient. But remember, the registration is for patients who have exacerbations and a phenotype of chronic bronchitis and a severe low FEV1. There is a study that's going to be reported, or I think it's been reported, where they looked at patients who have comorbidity of cardiovascular disease and COPD, where roflumilast was being used, but I haven't actually looked at that data.
Thanks, nice talk. My question is, I would like to have your opinion regarding the validity of this new classification. Because, as you know, there is a lot of countries decided not to use this new classification compared with the last one.
Yes.
And what is your opinion? Because there was a lot of publication showing that the different classification, the B, was had a higher mortality compared to the other class. So it's a bit difficult to choose and to say, oh, okay, it's a new goal and use it. And what is your opinion? Thanks.
No, I think that's a very good question. It's very controversial. And if you look at where it's been applied clinically, the C forms a very small category of most patients in practice. I think it's a good start in terms of using multiple modalities, meaning lung function, symptoms, exacerbations. But I think what needs to be built in is comorbidities, etc. And if you look at in clinical practice, it's nice for the practicing clinician to be able to categorize a patient into different severities. But at the same time, I believe seeing a lot of patients, when they come to you, it's because they've had symptoms or they've had exacerbations. And many of them, even in category B, as you say, already are exacerbating. So they may be misclassifying them, and they should actually be higher up in COD, and they should be treated differently. So that, for me, that is a problem. Our guidelines, which I chaired, is a bit outdated, but we looked at it and we said we'd like to have symptoms. We haven't brought in exacerbations then, and we probably will have to bring that in now as a determinant of severity. But I think the one lacking is comorbidities. The other big issue I have is many patients have non-smoking COPD, and we use all our smoking COPD data to treat those patients, assuming that they are the same. They're not, as you showed in your...
Yes.
Thank you. Thank you for your very clear exposé on this COPD, le BPCO. Je parle en français. First, I will talk in French first, then I'll put a question to you. Oui, donc je voudrais dire que là, on a ici beaucoup de pneumologues. Est-ce que vous savez quel est le muscle respiratoire? Le muscle principal de la respiration. The principal muscle for breathing. Do you know? Oui? The diaphragm. C'est bien. So the diaphragm is the most important. Le diaphragme, c'est le plus important muscle respiratoire. On est dans un pays ici de tiers-monde. On est, nous, à l'île Maurice, la Réunion, peut-être pas la Réunion, mais en Afrique. Et il y a un moyen de respirer correctement, c'est respirer abdominal. C'est pour ça que j'ai un gros ventre, c'est pour vous expliquer. N'est-ce pas? Donc on respire avec le ventre. Mais combien de personnes qui respirent avec le ventre? La respiration abdominale. La première question qu'on doit se poser. Et deuxième question, c'est que comment le yoga peut intervenir dans la respiration pour améliorer sans avoir besoin de toutes les complications des médicaments forcément. How can the yoga breathing, the hatha yoga, be important to the COPD patient? Because we are in an underdeveloped country where medication are not easily available. So how could you teach the people to breathe properly by abdominal breathing? That was my question for the population of the third world. Merci.
Thanks, Yuba. You always pose very difficult philosophical questions. I think just to answer it very simply, I don't have any data on that. and I don't think there's any firm clinical studies looking at it. But I believe, non-pharmacological treatments work, and if you look at rehab, if you look at physiotherapy, if you look at half-cuff methods, etc., that, in a way, maybe it does have some principles of yoga in it, but I can't answer your question.
Dernière question. Dernière question.
Yes. Sorry. Can I? Est-ce que je peux?
Hello?
Vas-y.
What about the role of combined treatment in appearance of pneumonia? And
Yes.
what's the place of rehabilitation in treatment?
Yes.
Thank you.
Okay, thank you very much. Like I showed you in the one slide, rehabilitation is vitally important, and it should be offered to all COPD patients of increasing severity, and probably from B upwards, I would say that's important. Combined ICS-LABA, no question, increases your risk of pneumonia because of the ICS component, and there is data for that.
So, Sad, sort of my question. When you're talking about coronary diseases, we're talking about inflammatory disease, and you use corticosteroid, right? Statin, sorry, for anti-inflammatory.
Yes.
Now, we know that COPD is also an inflammatory systemic disease. So, why can't we use, inhaled corticosteroid in this term? Can you explain it?
In COPD?
COPD, because being a systemic disease, so
Yes.
there is inflammatory,
Yes.
of course. So
I think there's no doubt that inhaled corticosteroids are of benefit in a category of patients, okay, with COPD, there's no doubt. And there are data looking at COPD with comorbid conditions and looking at the peripheral effects. And there is some data to show benefit, and I'm sure the manufacturers of ICS will tell you, but perhaps we should be looking outside the lungs. That is true. The use of statins in COPD, the post-hoc data showed it may have some benefit, but when a proper trial was done with the statins, it hasn't been shown to reduce COPD exacerbations using statins. So unfortunately, it hasn't worked.
Bon, nous remercions le docteur GAFFAR Abdoul pour ce traitement des BPCO. Merci beaucoup.